So what I'm going to do is I'm
Yes,
going
sir.
to start with
Hmm.
the sequence of talks that we have given,
Yes.
and then take it forward. I will request anybody who wants to discuss a patient, either they can put it in the chat box, or you unmute yourself, talk about your patient. Once we move on to the next patient, please mute yourself. That is what I will request. Is that all right, Dr. Soumya?
Uh, Good afternoon. This is Dr. Manoj Gupta. As I had discussed with my patient with you also on a
Mm-hmm.
personal chat.
Mm-hmm.
So I thought it will be nice that I put this the same patient on the forum.
Great.
20,
Let's start.
20, yeah, 25 years old girl
Hmm.
who was suffering from fever for almost
Hmm.
weeks,
Hmm.
and she had been running from one hospital to another, and she been put on monosap, multiple antibiotics, been investigated for dengue fever, typhoid, all sorts of tests done. And
Hmm.
finally, she came to me, considering that she's not been improving, so diagnosed as a case of PUO, definitely. And then, first thing what I did, my line of treatment, that let's stop all antibiotics,
Hmm.
because during my college days also my professor used to say, "Ki- if you give too much of antibiotics, that is also causes an antibiotic fever. Let's stop all antibiotics for few days and let the body recover on its own." What happened that when we did a CBC, there was a pancytopenia in when the TLC, which was around 3,500, went down to 1,200. And there was severe neutropenia also. Well, there was pancytopenia, what I could make out, and that's where I'd be discussed. And you had advised bone marrow. But then I said, let me just observe just by giving B12 to the patient. For 2 weeks of B12, when we gave, everything came back to normal, and patient was afebrile, and patient went home, and she's absolutely doing well. No further antibiotic was needed. She's absolutely fine now. So that is the final
Wonderful.
outcome, was just B12, and definitely your lecture on giving B12 to the patient here helped. I must say that.
Hmm. Hmm.
So that is what
Wonderful.
the
Hmm. Hmm.
thing is now.
Okay. Okay. Great. So I think this patient gives us a lot of topics for discussion. So fever was going around for how many days?
Fever was almost for 2 weeks, and it was ranging from 103, 104, 99. It never touched the baseline.
Hmm. Hmm. Hmm.
It never touched the baseline. So they were saying that we've been, and everywhere they were putting her, including she was on 7 days of monosep to be given at home only. They said, don't let the patient go home, stay
Hmm.
home. And every day she was taking. So when she came to me, another 2 doses of monosep was still pending. So I said, just stop it, because she'd been put on Septran,
Hmm.
ofloxacin,
Hmm.
ciprofloxacin, augmentin, monosep, everything was given to her.
Okay. Okay. And was there chills? Were there chills with the fever?
No, sir, nothing of that sort. It was only definitely when there was fever rising, she was feeling cold, but that is
Hmm.
a quite a natural one, not that shivering malarial kind of a thing. Wasn't there? Even malaria parasite was not there. Typhoid was negative. Uh, Everything was negative. That dengue was negative. There was nothing on. So only and only that she had, that time she had neutrophils were high, lymphocytes were low. Later on, lymphocytes become high, neutrophils low. But after 2 days of stopping antibiotic, she suddenly dropped all pancytopenia. That's when we asked, so you should go for bone marrow examination. So
Got it.
but since after stopping the antibiotics, she was afebrile. I said, only continue B12 for 2 weeks. We'll see after 2 weeks what happens. Everything become normal. She's absolutely fine. Uh, no fever, nothing. She was absolutely fine after that.
What was the hemoglobin and platelet count?
Sir, I don't have the report right now, but
Roughly, roughly.
because otherwise I would have kept the report, but I don't
Yeah,
have the report right now.
yeah. So
Yes,
I
sir.
think I'll look at our discussion on WhatsApp. All right.
Yeah,
Okay.
I'll also open up. Let me see if I can get to the patient thing also. Let me see that chats.
Yeah, yeah, yeah,
Let me see the chats.
yeah. So I'm
Uh,
looking at
it must have
the
gone fairly down. Let me see the chats.
yeah. Okay.
Yes,
नहीं वो chat में it doesn't have. All right. And cough, urine motion, everything was fine.
हाँ sir, everything was fine. But just एक case discuss कर रहे हैं. We'll Hmm, just let me see. It must have gone very down.
ठीक है.
Uh, just.
Wonderful. So, I'll just, for everybody's benefit, this is a 25-year-old girl who had fever, high grade, continuous, not touching the baseline for 2 weeks, and health probably falls into, something like a PEO, pyroxia of unknown origin. Now, whenever any patient has a fever and comes to us, what all of us look at is what are called as localizing signs of infection. And typically, the common sites of infection where, uh, uh, which can give us localizing signs are especially upper respiratory, lower respiratory, bowel, bladder. And these
Sir,
sites,
I got the report. I'll
yeah,
just share the report with the you can make it down. TLC was 2.40. That was
okay.
on 20th January 2025.
Hmm.
Neutrophils were 5.40.
Mm-hmm.
Lymphocytosis developed 72.50.
Hmm.
Monocytosis developed 12.90.
Hmm.
Eosinophilia developed 9.20. That was on 20th January 2025.
Mm-hmm.
Then
Hemoglobin and platelets.
platelet that time, just a minute. Platelet. 217.
Okay.
Then when she did the reports, that was on 25/1/2025. Her TLC came to 5.50, neutrophils came to 32.60, lymphocytes 46.80, eosinophils 7.60, monocyte 12.30, and platelet were 385.
385. Okay.
Yeah. So
Hmm.
that was only on B12. And after that, this was last conversation was on 31st January. After that, she did not come, but says she's absolutely fine. No further blood tests were then ordered. And so she
Wonderful.
recovered completely.
Wonderful. So, whenever we have any patient with fever, we try to see if they have chills and rigor because chills and rigor mean something different. Chills and rigor generally mean that either it's malaria or there is some kind of bacteremia. Essentially, what that means is there are some bugs floating around in the blood. They could be malarial parasites, they could be bacteria. Uh, we look at the localizing signs of infection, which are typically respiratory, upper or lower, and genitourinary and GI. Now, if you look at these localizations of infection, what that actually means is our body is actually covered by skin. Our entire body is covered with skin. And skin is the boundary wall which separates the inside of our body from the outside world. Okay. So skin separates the internal part, organs, and everything from the environment. That's the boundary wall. And wherever skin doesn't cover is where it's easiest for any microorganism to get inside the body. So the air which goes in, there is no skin in the upper respiratory tract. It's just a mucosa. Even going down into the bronchi and the bronchioles, it's easier for bugs to penetrate, whether they're viruses or bacteria or even fungi. Similarly, the genitourinary and the gastrointestinal tract. Now, gastrointestinal from the mouth down to the perianal and the colon. What is important is our nature has given our body a lot of protection. So, air which goes in. It's not common that every day we get an infection, right? Only when there are particular infecting organisms in our environment, in the people who are around us, so influenza viruses, rhinoviruses, or even tuberculosis. There are actually very few organisms which are able to breach the mucocutaneous barrier boundary. Similarly, for our gastrointestinal tract, whenever we eat anything, and we eat and drink every day, multiple times in a day, you can imagine how many bacteria, viruses go inside. But as soon as it goes in through the mouth and esophagus into the first bag which holds the food, that is the stomach. Stomach actually has hydrochloric acid, which kills a lot of the bugs. So body has such mechanisms to ensure that we don't fall sick every day. Nevertheless, whenever we fall sick, usually these are the organs from where infection goes in. Now, when it goes in and our patients come with fever, we typically think of, well, if there are no localizing signs of infection, maybe it is a viral infection, or the other common infections in our part of the world, that's malaria and typhoid. We will not get into how to diagnose malaria and typhoid. That's not the focus of this series of lectures. So I'm going to leave that aside. But if we consider that these are the common infections, which are viruses and other tropical infections like malaria, typhoid, how do they actually affect the blood? What actually happens? Now, if you listen to what Dr. Manoj told, initially, this lady's body reacted by pushing out more soldiers in the blood. So, initially the WBC counts were good, and most of them were neutrophils, because neutrophils are very rapidly acting macrophages. So, the bone marrow went into overdrive and started pushing out soldiers into the blood, leading to slightly high WBC counts, and most of them being neutrophils, because they are important for quick control of the infection. However, later on, this patient's WBCs kind of went down. And if you remember in the talk that I gave on platelets and WBCs, I said that what's important is what was the initial WBC and platelet count. Okay. If initially itself the patient comes to you with neutropenia and low platelets, that's not a good sign. Probably what that means is that the patient's immunity was low, because of which there was an infection. Okay. However, this patient does not fall in that. In this patient, the immunity seemed to be okay when she presented with infections. So maybe it is the infection which is reducing the WBC count rather than low WBC count causing infection. Now, all of these are hypotheses. Okay. These are not diagnostic observations. So, in this patient, retrospectively thinking, what we can make out is that she had B12 deficiency, and she got an infection, probably a viral infection or a bacterial infection. We don't know. There is no culture positivity. There are no localizing signs. There's no X-ray, etc., or she does not have any symptoms of UTI. So we truly don't know what it was. But it was an infection which pushed the marrow into overdrive. And whenever the marrow is in overdrive as a factory, it needs more it needs more raw materials to make the WBCs, right? And these raw materials are iron, B12, and folate. And when there is deficiency of B12 and folate, uh, uh, after some time, the marrow production will come down. The marrow production of WBC will come down. That's why maybe she later on had low WBC. Now, how do we say, hey, look, um, this patient, I want to go ahead and do a marrow, or I don't want to go ahead and do a marrow. And at that point, uh, so let me first come to differential diagnosis. So this was viral or bacterial or parasitic infection. No, by parasitic I mean malaria, right? Second, there could have been an underlying marrow problem with low immunity, so low WBCs, right? And that could have caused a secondary neutropenic infection, and or there was a underlying B12 deficiency, right, with viral or bacterial or parasitic infection or infestation. Now, how do we differentiate? This is where we come to what is high risk cytopenia and what is not high risk cytopenia. Now, high risk cytopenia is typically something where more than one cell line is affected. See here, the WBCs are low, but the platelets are good. In fact, as time went on, in the patient's course of the disease, the platelets increased from about 200,000 to 300,000, right? From 2 lakh to 3 lakh, which means that platelets are increasing. So probably there is not a major marrow issue. Yeah. And however, the cell line which is excessively being manufactured is going down because of B12 deficiency. Now, all of these is, post hoc. All of this is post hoc analysis. You never know when the patient is front of us what actually is happening. But I
Should I
think,
tell you the complaints of this patient? Now I got
please.
the now the it she came to us on 17th of January. So
Okay.
she had light fever since 15 December with upset stomach.
So
And
almost 1 month.
she was treated for enteric fever, loose stools, fever recovered but recurred after 3 days. She was admitted in hospital. Blood culture was positive for enteric fever. No fever since 29th December. As febrile for 3 days from 6th January, fever recurred. Taxim 400 and Septran DS were given. CBC and urine were normal. CRP was 25. Started on Ferranum and Septran for 3 days, then afebrile. Today is the last dose. Throat irritation since morning. Body pain and eyes paining. Temperature was 100 at 9 a.m. Temperature came down to 99. Rash over forehead. The past
Uh,
history was history of severe pain in abdomen, constipation, anorexia. Ultrasound abdomen showed hepatomegaly and cholelithiasis and PCOD.
so the
CT,
stomach upset was essentially constipation, you're saying.
CT abdomen was mild pelvic inflammatory disease.
Okay. So
So I made a
constipation
diagnosis
is
of
not a
PUO with
localizing
acute
signs of,
gastritis.
sorry.
I made a diagnosis of PUO with acute gastritis.
Okay. So stomach upset, you typically mean in this patient, it was constipation.
Constipation.
Okay. So constipation is not a localizing sign of infection. Generally, when there is a GI infection, we are going to get a diarrhea, right?
Diarrhea. Absolutely right, sir.
So in this patient, we can still say there were no localizing signs of infection.
Yes, sir.
Now, did you say that blood culture was positive for enteric
Enteric fever. But
blood culture? So salmonella positive?
just it says blood culture was positive for enteric fever, enteric salmonella infection.
Ah, that's something fantastic.
Sir.
So here now you essentially have blood culture positive for salmonella. So this is enteric fever. This is
Enteric
not a
fever.
PUO. Yeah,
Hmm.
this is enteric fever.
But
And
then this was on from fifth. This was the although I don't have a report of the blood culture report, but she was put on Taxim 400 and Sepran DS after that.
hmm. Okay. So essentially, this is a patient with diagnosed salmonella, typhoid, right?
Typhoid.
Typhoid fever, who in the course of her illness, the WBCs dropped, probably because of underlying B12 deficiency. Could also
Hmm.
be as a, because of typhoid fever itself, right? There could be some marrow suppression, and that's where we are. And the decision essentially was, should we do a bone marrow examination in this patient or not? So we are again coming to, while evaluating such a patient, does she have what I call high risk cytopenia, which is not there. The platelets are all right generally, in the blood cells, neutrophils and platelets have the shortest half life. So whenever there is a marrow problem, either a plastic anemia, that is bone marrow failure, or a leukemia or lymphoma infiltrating the marrow, the neutrophils and the platelets are the first to go down, which did not happen in this patient. The platelets were good. So maybe you can say, hey, maybe I'm going to hold off on the marrow, because the WBCs may be low because of the infection per se, infection suppressing or consuming the WBCs. And the platelets have in fact gone up, since platelets are acute phase reactant. So like our ESR, ferritin goes up, during any infection, any inflammatory state, platelets also go up. So you thought, okay, you have only one cell line affected, only WBCs, platelets are good, hemoglobin is fine. So this is not high risk cytopenia. Also, was there any hepatosplenomegaly?
No, sir. No hepatosplenomegaly.
Okay. Any lymphadenopathy?
No, sir.
Okay. Okay. So you could then comfortably say, look, liver spleen is fine, no lymph nodes, only one cell line. I'm going to hold off on the marrow exam, and maybe I'll just give B12 injections. Did we do a serum vitamin B12 or folate level?
No, sir. Not because I said let recover first, then we're going to further investigate you thoroughly from the start. Let me just put you on B12 for 2 weeks and then we'll see that. But she
Okay.
recovered.
Okay. And so, it would have been great to kind of have a beta layer, because then we would have a clinching diagnosis. But I understand. What about LDH?
No, sir, that was also not done.
Okay. So here, it would have been good to have a LDH. If it is high, then, you would suspect a malignancy. Um, in this patient, did you give any steroids?
No, sir.
Okay.
Only plain Neurobion 4. That is all.
Okay, good. So if you are not, if you take a clinical decision to not do a marrow immediately, then as we have discussed previously, most importantly, do not give any steroids before doing marrow exam, because steroids can kill lymphoid blasts, and you can miss the diagnosis of acute lymphoblastic leukemia, right? So as long as you are watching the patient, they're not running away, you're going to follow up like Dr. Manoj has done, avoided marrow, made a clinical diagnosis of maybe B12, and plus it was typhoid. And he said, I'm not going to do the marrow now. Fine, follow up closely, and absolutely no steroids without doing the marrow, because you don't want to miss the diagnosis of acute lymphoblastic leukemia. Okay, great. So this was a good patient. Next, let's move on to the next patient. So anybody has any other patient that they would like to discuss?
So in this patient,
Yeah.
if vitamin B12 was not done with the CBC, if the MC was a little bit high and peripheral smear was showing macrocytic picture, so then we could have thought of B12 deficiency.
Not really, because see, MCV can be high in a variety of conditions. Okay, so MCV high is not diagnostic, but it can indicate megaloblastic anemia, but it's not diagnostic. Um, polymorphonuclear neutrophilia. What that means is, you have neutrophils with multiple lobes, more than 5 or 6 lobes. Can happen in sepsis. So that again is not diagnostic. And Yep. These can indicate high MCV, and multilobed neutrophils can indicate B12 deficiency, but in the context of a fever, they are not really diagnostic. And the only thing that you can do is look at the other high risk signs for cytopenia and watch. If you're going to give B12, tell the family, look, I'm going to try this, but if you don't recover or your fever gets worse or platelets start dropping, we will be doing a marrow. And until then, I'm not going to give steroids. Any other question?
So regarding B12,
Hmm.
nowadays we are seeing patients with report of homocysteine levels little bit high, more than
Hmm.
13, 14,
Hmm.
and they are recommending B12 supplementation.
Hmm.
So what is your comment on that, sir?
Well, if the homocysteine is high, you should do a B12 level before you correct, because we don't want to miss, congenital problems related to hyperhomocysteinemia. So if just based on homocysteine level, it's not a good idea. Do a B12 folate level and figure out if that is truly contributing to this before you treat it. See, before we treat anything in clinical medicine, it's important to reach a diagnosis, right? Will we treat somebody as having, see, somebody comes with chest pain. Will we treat them like a heart attack without doing troponin or ECG? No, we won't. Similarly, someone coming with something and you're suspecting B12 deficiency or whatever it is, you should evaluate, establish the diagnosis, right, before treating it accordingly.
Thank you, sir.
You're welcome. Any other question? Any other patient? Okay. So we have a Dr. Pradeep has sent a message. 20-year-old lady, recently diagnosed pulmonary tuberculosis, about to finish intensive phase, has fever for 5 to 6 days, and there is pancytopenia. So hemoglobin is 4. Uh, Hemoglobin is 4, and platelets are 60,000. WBCs are 3,000. And there is vitamin B12 and folate deficiency. Reticulocyte production index tells us that it's a production issue. Diagnosis ATT induced bone marrow suppression. Stopped ATT for 3 days, started B12, 1 unit BRBC. In the last 2 weeks, incidentally, three doctors called me about exactly similar presentation. So newly diagnosed tuberculosis, all three had pulmonary tuberculosis, and in at least one, yeah, but two more doctors called me, and in at least one patient, the the sputum was positive for AFP. So it was clearly pulmonary tuberculosis. They got ATT, and then they presented with pancytopenia, and one or two patients B12 was low. And when all three patients, when they were treated with multivitamin B complex, the pancytopenia reversed. So I don't know whether ATT can precipitate a megaloblastic crisis or something. I'm not sure. I didn't get a chance to read about it, but it was fascinating. Right, Dr. Pradeep, did you get a chance to read whether ATT can precipitate megaloblastic crisis? So yeah, isoniazid can, right? So, it would be interesting if you, Dr. Pradeep, if you give me time tonight, I will read about whether any drug in ATT can precipitate a megaloblastic crisis, in which we should publish your patient as a case report. Okay, so Dr. Shirisha wants to know about pernicious anemia because she's seeing many patients with B12 deficiency. They have hair fall, tongue and knuckle pigmentation. When and who should be evaluated for pernicious anemia? How often should pernicious anemia patients get B12 injection? Will they need blood transfusion? So, very good question, clinically relevant, Dr. Shirisha, essentially wanting to know about pernicious anemia. So, I'm going to start this new patient's discussion here under the heading of megaloblastic anemia. So, well, whom should we evaluate for pernicious anemia? What I do personally is when I have somebody with newly diagnosed megaloblastic anemia, okay, whom to evaluate for pernicious anemia. What I do is young patient, okay, vegetarian, or whatever is the age, vegetarian patient. Let me just say whom not to evaluate for pernicious anemia. Maybe that is the way we should handle this question, because all of us see so many patients, right? So vegetarian patient, and first episode of B12 deficiency, no other autoimmune issues, so no other autoimmune problems. So what I mean by that is we don't have hypothyroidism, hyperthyroidism. We don't have type 2 diabetes, mellitus, right? And so in such patients, first episode, clearly vegetarian, they have never taken non-vegetarian food. I don't test for pernicious anemia in the beginning. However, it's all right to test even if you like, even in such patients, because how do we diagnose pernicious anemia? Well, it's very simple. What we do now is we do the antibody test. So anti-parietal cell antibody and anti intrinsic factor antibody. So anti-parietal cell and anti-intrinsic factor antibody. This is the blood test that we do. The other older tests are no more done. If you just do this blood test and if it comes positive, you call it pernicious anemia. And you should also, of course, do an upper GI scopy to look for gastric atrophy. If this is positive, let me tell you, I've done these tests. I routinely do it in patients who have B12 deficiency. In most of the patients, it's negative. Then why should we test for it? Because such patients need lifelong injectable B12. You have to give it lifelong for somebody with pernicious anemia. They're not going to absorb oral that well properly. And you're also going to watch for subsequent development of other autoimmune problems such as hypothyroidism and secondary diabetes mellitus. A very, very small group of these patients could also get autoimmune rheumatologic issues and rarely lymphomas, but very, very rare. Now, why don't I test this in every patient? Because even if we say that we are on a non-vegetarian diet, a true non-vegetarian diet, the way you see in North Americans or in Europeans, is they have chicken for breakfast, lunch and dinner. So they'll have a ham sandwich or a turkey panini, right? So they essentially have proper non-vegetarian diet for all three meals. Whereas in India or most of Southeast Asia, When we say we are non-vegetarian, means that we occasionally have non-veg. We have fish and meat once or twice. Um, in a week. We, of course, have non-veg during parties and weddings, but very few amongst us have non-vegetarian on a daily basis. So even if we say that we are, no, no, I have non-veg food, we don't really have it every day. So we don't get a good steady intake of B12. I treat patients with B12 injectable, and I follow them up. And truly, if somebody says, no, I have a regular non-vegetarian, they still have B12 deficiency, then I will look for pernicious anemia, essentially by doing the blood test for antiparietal cell and anti-intrinsic antibody, and they need B12 supplementation their entire life. Now, whether they need blood transfusion, I'm going to write down, the indications for blood transfusion now. This, I think, is going to be very important for all of you. Um, Indications for blood product transfusion. Okay. And let's start with packed red blood cells. Some of you will ask, what about whole blood? Why can't we give whole blood transfusion? You can give whole blood transfusion. It's not that you can't give. And if you don't have access to packed red blood cell, and your neighboring blood bank says, no, I only have whole blood, sure, you give whole blood. But in modern transfusion medicine, we don't do that because excuse me, one whole blood can be divided into three blood products which can benefit three patients, right? One person can get packed RBCs, one person can get platelets, and third person can get plasma, FFP, cryoprecipitate, all that. So we discourage the use of whole blood because we can otherwise with the component therapy, by dividing the whole blood into red cells, plasma fraction, and the platelet fraction, we can help three patients rather than one. The other reason we discourage whole blood is because it leads to volume overload. And lastly, because the transfusion reactions are higher. See, it is the plasma proteins in the plasma and the WBCs which lead to all the fever and rigors during blood transfusion. So if you're giving packed red cell, you're removing the plasma component, and you may also be able to remove some WBCs, thus reducing the risk of febrile transfusion reaction. So we recommend that whenever hemoglobin has to be increased, please use packed red cells. Now, when do we give packed red cells? Okay. If it is nutritional anemia. Okay. So nutritional anemia, which essentially means iron, B12, or folate deficiency. In iron, B12, or folate deficiency, young patient, okay, or older patients, okay, and if they are hemodynamically stable, which means that they are not in cardiac or respiratory failure, because iron, B12, and folate deficiency happens slowly over many years, and hence the body adjusts. And even when these patients come with very low hemoglobin, they are generally not breathless. They may look very pale. Hemoglobin may be 4 or 5 or 6, but the body has adjusted. They have compensated anemia, right? So if they are hemodynamically stable, right, they are not in cardiac or respiratory failure, okay, in such patients with pure nutritional deficiency, again, by pure, I mean no hepatosplenomegaly, no lymphadenopathy, you're not worried about bone marrow failure, you're not, Ashish is going to talk about this. We are not going to have, we are not looking at bone marrow failure, we are not looking at leukopenia, we are not looking at leukemia, but just nutritional anemia. In such patients, we transfuse if HB is less than 5 gram percent in a stable patient. But remember, if if you know this is iron, B12, folate, hemoglobin is 6, and you say, no, no, this is more than 5, I'm not going to give you blood. Okay, you have to follow up the patient every day, because they may go home or they may go somewhere else. Somebody gives just a normal saline infusion, and that 100, 200, 500 ml of NS can decompensate them. They may go into cardiac failure or pulmonary edema. So if we choose not to transfuse patients with nutritional anemia because the hemoglobin is more than 5 grams, you have to ensure that you keep a close watch on the patient. So this is the indication. For autoimmune hemolytic anemia, it's the same. If they are hemodynamically stable, no cardiac or respiratory failure, we don't transfuse unless the hemoglobin drops below 5 grams. Okay. For all other causes of anemia, so these other causes may be anything. They may be trauma, they may be, intraoperative bleeding, right? So intraoperative hemorrhage, this may be a postpartum hemorrhage, right? It could be leukemia, any marrow problem like leukemia, aplastic, or post chemotherapy. In these patients, other types of anemia, the transfusion target, rather the threshold for transfusion, is if hemoglobin is less than 8 gram percent. Okay. So all types of anemia, it can be anything. It can even be, an ICU patient with anemia. And you don't have to transfuse blood until hemoglobin is less than 8 grams. And there have been good number of studies showing that even in exceptionally sick patients who are in ICU, if you maintain a higher threshold of hemoglobin. So, there was a wonderful clinical trial, I think it was published in NEJM, that if, in half of the patients, they kept a threshold of 8 to 9 grams, in the other half, they kept a threshold of 10 grams. So, the threshold was if the hemoglobin goes below 10, you give blood, right? These are sick patients in ICU. And the hypothesis was sick patients who are on ventilator, maybe if we maintain higher hemoglobin, there are a lot of RBCs then to collect, to take hemoglobin to all parts of the blood. You won't have tissue hypoxia. You won't have tissue hypoxia. And they actually saw that by keeping a higher threshold for blood transfusion, it did not improve the outcome. And in fact, in some patients, there was a worse outcome. There's a worse outcome. Because remember, when we give somebody else's blood, you're also giving their antigens, their plasma proteins, their WBCs, and all of these go inside the body and they lead to an inflammatory state because you are giving somebody else's blood, you are giving new antigens, it can lead to a inflammatory state. And that inflammatory state might actually worsen the outcome of whatever is the reason why the patient was put in the ICU in the first case, whether the patient was put in the ICU for sepsis or pneumonia or complicated UTI or trauma. Just giving additional blood it does not help and might actually harm. So these are the thresholds for giving packed red cell transfusion. I will also just tell you what are the indications for platelet transfusion. Okay. Now these indications are divided into three types. So, some patients, we wait till the platelet count is less than 10,000. In some patients, we wait till the platelet count is less than 20,000. And in some patients, we wait until platelet count is less than 50,000. And in some patients, we transfuse to maintain platelets uh, um, at 1 lakh. So when do we do this? So 10,000 is what we follow when we have patients who are undergoing chemo or stem cell transplant. Yeah, so stem cell transplant. Um, We don't transfuse platelets in our unit if the platelets are more than 10,000. And there is again good research on this to show that trying to keep a higher platelet count does not reduce bleeding. Okay. So platelet count less than 10,000 chemo or stem cell transplant patients. For you, patients who have dengue fever, right? You can wait till 10,000. If there is no bleeding and PT and APTT are normal. What this means is even in dengue fever, the bleeding is actually caused by organ dysfunction. And it is actually caused because the coagulation factors also go down. Remember, to form a clot, we need all three things. We need the vascular endothelium, the platelet surface, as well as the coagulation factors, which we test by doing PT-APTT. PT-APTT tells us if there are enough coagulation factors in the blood. Now, if in dengue fever, there is some bleeding or PT-APTT is deranged, then you can even transfuse if the platelets are less than 50,000, especially if there is bleeding and PT-APTT are deranged, right? So bleeding changes the equation. Bleeding changes the equation. So any bleeding, right? The bleeding could be due to ITP, could be due to dengue fever, could be post chemo. So post chemo or during stem cell transplant, if I have a patient who has bleeding, then I will try to maintain a higher platelet count of 50,000. Okay. And finally, um, in whom do I maintain 1 lakh? 1 lakh is for patients who are going through critical surgery. Okay, critical surgery, and so they're going through neurosurgery, orthopedic surgery, any what we call where there can be potential third spacing, so abdominal surgery or lung surgery. There are low platelet count. The anesthetist may say, no, no, I want at least 75,000 or 100,000, 1 lakh platelet count. Fair enough. You could try to do that, but not in ITP. Okay, critical surgery. But the platelets are not because of ITP, but if that's important, but the patient should not have ITP. What this means is in ITP, because there is immune consumption of platelets, whatever platelet transfusion you give is going to get consumed. You're never going to get 75,000 or 1 lakh platelet count because the patient's immunity is just chewing up everything that you transfuse. So in ITP patients, we go ahead with neurosurgery even if the platelets are 2,000 because you can't increase the platelet count, right? And we routinely do splenectomy in ITP patients when the platelet is 5,000 or 8,000. And that scares the anesthetist and that scares the surgeon saying, hey, how can I operate your ITP patient who has low platelet? And we say, boss, you can never increase it. That is the first thing. Especially in urgent surgery. Sometimes ITP patients will come with head injury and subdural. You don't have time to give IVIG and increase the platelet count, right? You have to go in and immediately evacuate the subdural hematoma, or the patient will keep on bleeding because of low platelets and die because of cerebral herniation. So in such patients, what we do is we ensure that PT-APTT are normal. We ensure, we tell the doctors, the surgeons, just take this patient to the OT. This is an emergency surgery. We don't have time to give IVIG and increase platelet count, and we will give platelet transfusions throughout the surgery. So we don't give 8 platelets, 6 or 8 RDPs and send to ICU, send to the OT. No, we say, look, we are starting platelet transfusion. You start the surgery, and throughout the surgery, we will continue to give one RDP after another, because the half-life of transfused platelets in ITP patient is a few minutes. So if you give 6 RDPs before surgery, intra-op the platelet count will go down. But if you keep on giving one after the other through the surgery, maybe the blood platelet count would be good. So these are the indications. Now, what about, you will say, Sachin, when do you maintain, 20,000? We do this for chemo transplant or aplastic anemia patients, uh, uh, and aplastic anemia patients when they are followed up in the outpatient. So when I'm discharging a patient and I'm saying, okay, look, your platelets are low, they'll take some time to recover, come back after 2 3 days, then I want to maintain about 20,000 and send them. I'm not going to risk it because the patient is not close to the hospital. If they're admitted, I don't care if the platelet is 11 12,000, because at that point the threshold is 10,000. Okay, so these are the thresholds for platelet transfusion. Any other question? All right, I think we are also close to 5 p.m. Um, there's another uh, a piece of information that I would like to give you is what is the difference between RDP and single donor platelets? Okay, a very important topic. So I'll just write this here. Between random donor platelets and single donor platelets. Okay, so one single donor platelet. Okay, before we do that, let me just tell you what is an SDP. So a single donor platelet, also called SDP. Yeah, this is created. This is collected by apheresis. Yeah, this is kind of concentrated platelets, concentrated. Yeah, and one SDP, one single donor platelet, is equal to 6 to 8 RDPs. Okay. Now, what is RDP? That is called as random donor platelet. Yeah, RDP. This is created from whole blood transfusion. So whenever we go to the blood bank and we give blood, we give one packet of whole blood, right? So created from a whole blood bag. Yeah, and one bag of whole blood will give one random donor bag. Okay, so you need 6 to 8 whole blood donations to get 6 to 8 RDPs, whereas one person can donate one SDP. Yeah, by apheresis from one donor. Okay, if you are giving one SDP or 6 to 8 RDPs, it's absolutely fine. There is no difference between the two. Okay, so one SDP is equal to 6 to 8 RDPs. Yeah, so this is the dose of platelets for one adult patient. Okay, so let's put this as platelet dose. How many platelets should we give? Right? How many platelets should we give? So for adults, you can give one SDP or 6 RDPs. All right. And for children, yeah, you need to give one RDP per 10 kg body weight, roughly. So this is the rule of thumb I'm telling you. All right. So for a 10 kg baby, you can give one random donor platelets. For 40 kg baby, child, you can give four RDPs or half SDP. Do you understand that? So four RDPs of half SDP, they are absolutely the same. Yeah. So difference between SDP and RDP. Okay. In terms of increment in platelet count, they are the same. So you give one SDP or 6 to 8 RDPs, you're going to get the same increment in platelet count. It doesn't, many people think that SDP is better. No, that's wrong. You give one of this or 6 to 8 of that for an adult, you'll get the same increase in platelet count. All right. The only difference is because SDPs are concentrated, yeah, hence the volume is low, is less. So if you're worried about fluid overload, then instead of 6 to 8 RDPs, you may choose to give one STP. That's it. There's absolutely no difference. And the only other difference is financial toxicity. So SDPs are more expensive. So in my department, we are very clear, don't give SDP. They're more expensive, right? You just give 6 to 8 RDPs. Why will you give SDP? Because both of them have exactly the same increment in platelet count. So I think this is it for today. We had a wonderful case from Dr. Manoj about a young lady with fever, which was due to typhoid. And at presentation, she had good neutrophils. In fact, proper neutrophilia, and later on the neutrophil count went down, but the platelets remained good, and there was no hepatosplenomegaly, no lymphadenopathy, and she took the clinical decision of not doing an early marrow. Yeah, he thought that, hey, this is not high risk cytopenia because only WBCs are low, platelets are good, HB is also okay, right? And hence he chose not to do this. He gave multivitamin B complex, but he continued to follow to ensure that later on, if the platelets would have dropped, he would have definitely done a marrow exam. He also did not give any steroids because he didn't want to miss the diagnosis of acute lymphoblastic leukemia. uh, we discussed a little bit about megaloblastic anemia, when to evaluate for pernicious. Well, you can evaluate for every patient of B12 deficiency. You can evaluate for pernicious anemia. Nobody can say why you're doing this. It's absolutely valid. The test today is anti-parietal cell and anti-intrinsic factor antibody test on the blood. And if it's positive, this patient will not be able to absorb oral B12, so they need a 3 monthly B12 injection lifelong. And that's how it is. We spoke about indications for blood transfusion, packed red cells in nutritional anemia. If they are clinically stable, no cardiorespiratory failure, then we wait until the HB drops below 5. Same cutoff for autoimmune hemolytic anemia if they are stable. However, for all other causes of anemia, whether it is trauma, post-operative, postpartum, leukemia, aplastic post-chemo, the cutoff is 8. The reason for these two conditions, the cutoff is 5, is because they are generally slowly evolving anemias, and patients are clinically stable. And in autoimmune hemolytic anemia, the cutoff is 5. It's very difficult. It's like ITP, you can never increase the platelet beyond a limit. Similarly, for autoimmune hemolytic anemia, the platelet, it's very difficult to increase HB, keep a very high HB. So we keep a conservative hemoglobin of 5. Platelet transfusion, for us as hematologists, for our patients with leukemia, aplastic, post-transplant, the cutoff is 10,000, unless they're getting discharged, when I would like to maintain 20,000 for safety. In dengue fever also, it is 10,000 is the threshold for platelet transfusion if there is no bleeding and PTABD are normal. However, if there is bleeding, whatever is the cause, it may be dengue, it may be ITP, it may be post-chemo transplant, we maintain 50,000. And for critical surgeries, the platelet transfusion threshold is 1 lakh or 100,000. There is absolutely no difference in random or single donor platelet when it comes to what is the increment in platelet count after transfusion. The only difference is that single donor platelets are concentrated, so smaller volume, whereas 6 to 8 RDPs, you're giving more fluid volume. And the other difference is that single donor platelets are expensive. So that's it for today. And if anybody has any other question, feel free to send it in the group or as a WhatsApp message to me. Now, just a point to remember, I may not be able to follow all the messages. So if there's a patient that you want to discuss and you've posted their reports in the group or directly sent to me as WhatsApp, just call me and tell me to look at WhatsApp, because sometimes I'm able to see WhatsApp only once in 3 4 days. So that's about it. That's it from my side today. Again, I will share the Word document in our group and I'll upload the video of today's talk. It was a pleasure to have a freewheeling discussion and cover some topics which we are not able to cover in detail in a structured class. Thank you so much. And
Thank
Dr.
you,
Sachin,
Dr.
over
Sachin.
to
I think
you.
it was a wonderful impromptu session with all the case-based. I think our level of approach with respect to hematology cases, I think you would also agree that we have definitely improved on that. So thank you for this enlightening session. And I think next week, do we have a class?
Uh,
March 6th. Are you free, sir?
6th would be a bit difficult for me because I'm traveling.
Okay.
We have one pending class by someone, right?
Yes, I would check with others, sir. Huh? Whoever is
Okay.
available, I'll
Okay.
check with it, and dear participants will be posting it well in advance after
Yeah.
checking with the concern.
Yeah.
Okay. Thank you,
So
sir.
if nobody else is taking, I will take the myeloproliferative neoplasm class. So PV, ET, and PMF on 6th. Just let me know a couple of days in advance
Yes,
and
yes. Before that, increase in hemoglobin, class on increase in
that's what. Yeah.
platelet
So
and
so if nobody else is taking, the next Thursday I will take that class on high HbWBC and platelets.
okay, fine. I'll check
Yeah.
with you. Thank you so much. Good day, sir.
Thank you. Bye, guys. See you.